Hi, in this video I'd like to cover what a breech baby is and why it matters, what your options are regarding how you can have your baby. This video doesn't replace the need for an informed discussion with your obstetric team, as it's very likely that there may be a factor that affects you which I haven't taken into account here, but I hope it explains lots of the terminology and things to consider.
So in this video, I am going to be a pregnant mum that has just found out that my baby is breech. So I'm going to have an appointment with my lovely obstetrician, Vicky. So I'm going to be asking questions that you may want to consider asking your own obstetrician if this situation happens for you. So Vicky, what actually is a breech baby?
Okay, so I'm going to use this chap to help me demonstrate, but a breech baby is when instead of your baby being head down, or what we call cephalic, which is what would happen towards the end of pregnancy, your baby is presenting with either their bottom or their feet. And this happens in about 3% of pregnancies after 36 to 37 weeks. And I'm going to describe this with regard to what's presenting and what the legs are doing, okay? So for instance, a flexed breech means that the baby is tucked up with the knees bent, but the bottom is the lowest part in the uterus. And it looks as though it's about to do a forward roll, okay? Now, a footling breech is also with the legs bent, but the feet are below the baby's bottom. And so that means that if you were to have a vaginal birth, then the feet would be the first thing to come out. Lastly, an extended breech. This child doesn't have fully articulated knees, so you have to imagine a little bit. An extended breech is where the baby's legs are straight and the feet are often up in front of the baby's face. And the bottom is very much the lowest part presenting. Okay, so why
are babies breech?
So, firstly, we often never find out. Okay. So you may go looking for answers that we can't answer. Sometimes it's because you've got an unusually shaped uterus. So if you've got a heart-shaped uterus, which is called arcuate, or you've got a small bit of extra tissue called a septum down your uterus, which you sometimes find out on an ultrasound scan, then it can be more difficult for the baby to turn towards the end of pregnancy. Similarly, having fibroids can create a barrier to the baby being able to turn around. The other thing is that if you've got very little fluid around your baby, or indeed loads of fluid around your baby, they can get either stuck in the position that they're in with not as much room to turn, or if you've got lots of fluid, they're just much more mobile in the uterus because there is more room to turn.
Somersaults.
Yeah.
Lovely.
Very rarely you may have a breech baby because the baby is not responding to the signals towards the end of pregnancy, and that can sometimes signal an underlying problem. It's really unusual, okay. But it would be remiss of me not to mention it.
How do you find out that your baby is breech?
So every time you see your midwife in later pregnancy, they should examine your abdomen and feel your uterus. And lots of midwives will be able to detect on what's called palpation, feeling your belly, that what is presenting is possibly not a head. And you also may be able to tell from the fact that there is very clearly a hard head at the top of your belly that you may suspect that that's what's going on. If that's the case, they'll send you in for an ultrasound scan to get it confirmed, and also to do things like check how much fluid is around the baby for the sorts of reasons that we've discussed. Sometimes you have an ultrasound scan for another reason, and it's discovered on that. And in a few cases, it's discovered in labour.
Okay.
Okay.
So when does it matter if my baby is breech and when not?
Okay, so if I were to discover that a baby was breech at sort of 32, 33 weeks, and there was no reason that you were going to have an early baby, it doesn't matter.
Okay.
But if, for instance, you're getting to more like the 36, 37 week mark, then that's when we would discuss potentially the fact that the baby might stay in this position and what you would like to do about that.
Okay, so as I am 37 weeks pregnant, what are my options?
So I'm going to summarise the three options and then we'll go through each of them individually.
Okay.
So the first is you can ask for somebody to try and turn your baby around for you, which is called an external cephaloversion. It literally means external, from the outside of your tummy, turning the baby's head, cephaloversion.
Okay, and that's sometimes called an ECV, isn't it?
Yeah, and I'm going to call it an ECV for the rest of this video.
Okay, good.
So the other two options would be that you aim for a vaginal breech birth, or you opt for a planned cesarean section.
Okay.
Okay.
So what is an ECV then?
So it's a procedure which is done in hospital, and you have appropriate monitoring of your baby's heart rate and their position using an ultrasound scan and the straps on your tummy called the CTG.
Okay.
And it's where an obstetrician, or in some units, a specially trained midwife, will attempt to turn your baby from the breech position round so that they are head down. And the reason why we offer this is because we know that if you aim for a vaginal breech birth, you're twice as likely, sadly, to have a baby that doesn't do well in labour. And so to talk about some of the cold hard facts, content warning, sorry, whilst these risks are small, ultimately part of this counselling would be that if you aimed for an elective section at 39 weeks, the chances of your baby dying in labour or up to 7 days afterwards are 0.5 babies per 1,000. Okay? If you aim for a head down vaginal birth, it's 1 per 1,000.
Okay.
And in a vaginal breech birth, it's 2 per 1,000.
Okay.
So we can improve the chances for your baby by turning them to be head down.
Okay, so that would be the benefit of going for
An ECV. Yeah.
Okay.
Okay.
Are there any risks with an ECV?
Yeah, I'm going to get onto it. So I'm just going to talk a little bit about what the procedure involves, and then we'll talk about the risks.
Okay.
So what ECV involves is that, first of all, you'd have an ultrasound scan to make sure that you've got adequate fluid around your baby, because if you don't have enough fluid around your baby, it's not going to be recommended. And they would detail the position that the baby's in, because when I'm going to do this, I'm going to aim to do a forward roll. So I need to know if the baby is this way around or this way around.
Yeah.
Okay. And I would ask for you to have a CTG beforehand, and then administer a drug called terbutaline. Now, what terbutaline is it's a tiny injection. It goes just under your skin and it helps to relax your uterus. It does have some side effects. It can make you feel like you've got a slightly racy heart. It is short-lived. And then my personal practice would be to then tilt the bed so that you're slightly head down. And the reason why I'm doing that is because it helps to disengage your baby's bottom from your pelvis.
That makes sense.
Okay. Then most obstetricians will use something on your tummy to reduce friction, because I'm going to put my hands on your tummy. I use either ultrasound gel or baby oil. Some people use talc, but essentially you're just trying to avoid friction burns on your tummy. Okay. Now, during the ECV, I would need to apply some firm pressure to your tummy to push the baby's bottom out of your pelvis. And then when I've done that, to hold the baby's head and to turn the baby slowly.
Okay.
Now that can be uncomfortable.
Will I have any pain relief?
Yes. So I would happily offer somebody some gas and air while I do it. It's generally not recommended that you have something like an epidural, because actually your feedback about how uncomfortable you're finding it is valuable in us making sure that we're not applying undue pressure.
That makes sense.
Okay. During that attempt, if I managed to get the baby's bottom out of your pelvis but got to sort of this sort of angle, but then they slipped back and you were happy for me to try again, it is considered fine to have an additional attempt.
Okay.
But if you need somebody to stop, or if that day that obstetrician feels that they're not able to do it, and you are still really motivated for a vaginal birth and you wanted to have an ECV, it's appropriate for you to ask to have it done potentially by a different person on a different day.
Okay, that's good to know.
regardless of whether or not your ECV is successful, we would always do a CTG afterwards to check that your baby is okay. Okay. And the reason why is that there is about a 1 in 200 chance of causing fetal distress.
Okay.
Okay.
So what's fetal distress?
So fetal distress is when your baby shows an abnormal heart rate,
Okay.
usually due to lack of oxygen, and so that might trigger the need to have an emergency cesarean section in those circumstances. So that's the kind of risk that you're dealing with. And some people are not happy with that, in which case there are some other things that we can talk about that might help your baby to turn. In terms of when we would do an ECV, we would normally do it at between 36 and 37 weeks pregnant.
Yeah.
And the reason why is because the baby is smaller than it would be at like 39 or 40 weeks pregnant. So chances of going round are greater. But if you're really motivated, if it was discovered at, for instance, very, very early labour, 1 to 2 centimetres, and your waters hadn't gone, you could potentially even have it done at that stage.
Okay.
But bearing in mind that if you're much further on in pregnancy, it's less likely to work.
Okay.
Okay.
Lovely.
So, other things to consider. If you've got a rhesus negative blood group,
Yeah.
this is considered a sensitizing event. So that would be one of those circumstances where if you've got a rhesus negative blood group, you should probably have some anti-D if you know that your baby is rhesus positive, or if you're in a district where we don't test the baby's blood group. And then afterwards, if you had reduced movements or bleeding or ongoing, abdominal pain, we would ask you in all of those circumstances to come back for additional monitoring to check that you and your baby are fine. Okay. Circumstances where I can't recommend ECV would be if you have twins.
Okay.
Because it's not possible to manipulate.
There's too much baby in there.
There's complicated factors, many babies. And also if there were concerns that your baby wasn't growing adequately, because actually you're more likely to cause fetal distress in those circumstances. Notably, if you've had one cesarean section, it doesn't seem to increase the risk compared to not having a scar on your uterus. So whilst some units might consider it a relative contraindication, i.e. it's a thing to consider that might mean that it's a no, the most recent guidance from the Royal College says that one section you should still consider offering this. Okay. When you do go into labour, if your baby has stayed head down, there is a slightly increased chance of you needing some form of assistance. So your chances of getting an unassisted vaginal birth are still a little bit lower than if your baby had been head down all along. Does that make sense?
Did you say a little bit lower?
So that means that your chances of needing an emergency section or an assisted vaginal birth are slightly higher, even after assisted.
Oh, I see.
Even after even after an ECV, if it's successful, slightly higher chance of needing forceps von Too's emergency section. But still lower than if you're aiming for a vaginal breech birth. Okay.
So how likely is the ECV to work?
So I can give general figures. And then I think the other thing to bear in mind is that different practitioners are differently skilled at this.
Better at it than others.
I think that's fair, right? Like if you do a lot of it, you're going to be better at it. But generally speaking, it's about 50% successful. And that is, I generally quote, it's about a third of women when it's their first pregnancy that it's likely to work, and about 2/3 of women when it's their second or subsequent pregnancy that it's likely to work. And that's because if your uterus is as big as it's ever been, first baby, 37 weeks pregnant, the uterus is tighter around the baby than if you've got to 40 weeks pregnant previously and now you're 37 weeks in a second pregnancy. Does that make sense?
That makes
sense.
There's
a bit more wriggle room.
And your abdominal muscles as well would be...
This is also true. Some people have astonishing abs at the end of pregnancy. I think the other thing to bear in mind is that if your ECV is successful, fewer than 5% of them will turn back. So when you next see your midwife, they should palpate and be happy that it's still a head.
Still head down. Okay.
Okay.
Lovely.
Fine. So in terms of things that you could do to increase the chances of your baby turning,
Yeah.
there is a useful website called Spinning Babies.
Yeah.
I would be a little bit sceptical about some of the evidence. There's not really any robust evidence that lying or standing in a particular position makes your baby turn.
Yeah.
I think the flip side to that is to bear in mind that I think some people feel that they're somehow at fault for having a breech baby, and I really want to dispel that because it's not anything that you've done. It's not because you sat on the sofa in a particular way at 35 weeks. One of the other things that you could consider, and there is some evidence for this and we really don't know why, is Moxibustion.
I've heard this.
So Moxibustion involves burning this Chinese herb called mugwort, and it seems to stimulate lots of movements, and in the stimulating of lots of movements it can increase the chances of your baby turning. This is not something that you're recommended to have a DIY go at home. This is something that you would do with a registered practitioner. They are often midwives who do this as an additional skill, but that is something that you could consider doing, and you're encouraged to do that at more like 34 weeks, but you could consider it a bit later. Okay.
So if I don't want to do the ECV, or if my ECV doesn't work, talk to me about a vaginal breech birth.
Happily. Okay. So you might choose, after having had a discussion with your team, that, as Beth says, it's not the right choice for you, or you're really motivated for a vaginal birth and your ECV hasn't worked.
Okay.
In these circumstances, you would be cared for by a team that are trained in helping women give birth vaginally who have breech babies. And I want to reassure you that everybody who practices obstetrics and midwifery in the UK in an NHS hospital has to do obstetrics emergency training, part of which is how you help women have vaginal breech births. And this is partly because sometimes people turn up in labour and that's the right thing to do for them. So the circumstances, if you were going to plan this, is that we would encourage you to have your baby on a consultant-led unit.
Okay.
And the reason why is because up to 40% of vaginal breech labours are actually going to end up being delivered by emergency section. Okay. And so you need early recourse to having an emergency section. And so being in a midwife-led unit away from a hospital or being at home is not going to allow you that quick access to getting to theatre. Okay. So whilst the success of vaginal breech birth carries the fewest risks to you as a mother, as we've discussed, there is a higher risk to the baby from having a vaginal breech birth.
And that was 2 per 1,000, you said?
2 per 1,000 perinatal mortality compared to 1 per 1,000 if your baby is head down born vaginally, and 0.5 per 1,000 if you have an elective cesarean section at 39 weeks.
Okay.
And partly, I just want to emphasise, partly that is because babies born by elective cesarean at 39 weeks then are out in the world, and so any, trigger warning, stillbirths that occur after 39 weeks don't apply to those babies that have already been born. Does that make sense?
Yes, that does,
Okay. So there is a risk if you have a vaginal breech birth of that happening. There is also a slightly higher chance of your baby having short-term complications, meaning that they need to go to special care. However, the evidence is that if you look at the long-term effects on those babies that had to go to special care for a short period of time, there is no difference when you look at, for instance, like IQ aged 5, that sort of thing.
Say that again, IQ aged 5.
Yeah, so if you're looking at long-term outcomes of children that were born by vaginal breech birth and then had to go to special care because they were born with, needing help for breathing, for instance, they still do well, but if you're a mother who has a baby that goes to special care needing additional help, that's still potentially traumatic.
Yes.
So I think it's worth bearing in mind that the events immediately surrounding the birth might be a bit different if you have a vaginal breech birth.
That makes sense.
Okay. So before you choose a vaginal breech birth, you need certain information in order to help make an informed decision. And that would include having a growth scan. And the reason why is because if you have a very small baby or a really big baby, you would not be recommended to aim for a vaginal breech birth.
Okay.
In a really small baby, your baby is more likely to experience fetal distress and need to have an emergency section.
Yeah.
In a really big baby, your baby is more likely to get stuck, particularly if they have a big head, because that is the last part of the baby to come out in a breech.
Yeah.
And if the baby's head becomes trapped in a vaginal breech birth, you might need some additional assistance.
Yeah.
And so forewarned is forearmed, basically. If you
Okay.
know that, then you kind of know that there's an increased chance that that's what you're getting yourself into. There are also circumstances where you might have a breech baby and it just wouldn't be recommended that you aim for a vaginal breech birth. So if your baby's head is tilted back a lot,
Like that.
that is less likely to result in a successful vaginal breech birth. Also, if you've got a low-lying placenta and that's why the baby is breech, you'd probably be recommended to have a cesarean anyway if the placenta is very close to or overlying the cervix.
Yeah.
Sadly, a vaginal birth is not going to be an option.
Okay.
Provided this isn't the case, then your team should inform you of the risks and benefits of vaginal breech birth and support you with your wishes. In labour, you would usually have the same choices of pain relief.
Yeah.
So I always kind of work from least interventional to most interventional.
Yeah.
So you could certainly use hypnobirthing techniques. You could use TENS machine. You could use gas and air. You could use pethidine or diamorphine. You could have an epidural. In terms of labouring in water, it's not an absolute contraindication, but you would be recommended not to have your baby in water. So you could use
So
it
the
for
actual birth you would get out.
Yes.
That would be the advice.
Yes. And I think what's worth bearing in mind is that some women find water so helpful that then asking them to get out for the birth is hard.
No.
So whatever you choose, you can still personalise that atmosphere. You can have aromatherapy. You can bring in some things from home that are going to make it feel like a more relaxing atmosphere for you. You would be recommended to have continuous monitoring. Okay. And the reasons why are that there is an increased chance of babies needing some help to be born, for instance, by emergency cesarean section. You're more likely to pick up on that early if you've got continuous monitoring than if you're using the Doppler.
Yeah.
The other thing is that it's recommended that you have an examination in labour to assess how low the baby's bottom is.
Okay.
And I say bottom because if you have a footling breech, you'd be less likely to be recommended to have a vaginal birth.
Yes.
Okay.
And why is that?
Well, so the reason is that because feet are rather smaller than a bottom, they can poke through an incompletely dilated cervix. So they can come through a cervix that's sort of 4 or 5 centimetres and stimulate your desire to push well before you're fully dilated.
Okay.
And the problem is that can lead to fetal distress.
Yeah.
Also, you're slightly more likely for the cord to come down with the feet. So
And
it's
that
important.
would be an
That would be an
emergency
emergency because the cord should stay in until the baby is out.
Yes.
Yes. So in terms of labouring with a breech baby, you don't have to be on a bed while you're labouring. But you would be recommended when you're actually having your baby to be in a position where your team feels that they are able to assist you if you need it.
Yeah.
Now, some teams in the country have been trained to assist with you in an all-fours position.
Yes.
Everybody in the country has been trained to assist you if you're lying slightly back. So what that means is you need a dialogue with your team to work out what they're going to be able to help you with.
Yeah.
And if that means that you need some assistance, that may sometimes mean turning from all fours onto your back if you're not already on your back.
And are those two the best positions then? Either is slightly on your back or on all fours. So, for example, not on your side or standing or...
So I think the thing is that if you're in those positions, your team will not be able to help you.
Yeah.
And so, of course, nobody can force you to be in any position that you don't want to be in, but you need to bear in mind that if the baby's bottom is not descending or if the baby's head needs some assistance, you're going to need to keep your ears open in order to respond.
Okay, that makes sense.
And in those circumstances where somebody says, I need you to get just onto your back so that I can help you a little bit, that is time critical. Like you need to be kind of responding within the minute. And if that is not a circumstance that you feel would be something that you would want to take into account when you're labouring, then it may be that vaginal breech birth is not going to be the right choice for you.
Okay, lovely.
Okay. So in some circumstances, there might be concerns about your baby's heart rate or your labour is not progressing, where you would be recommended to have an emergency cesarean section. However your baby is born, a neonatologist, who is a doctor who specialises in the birth of newborn babies, would be present however you have your baby. So they can be quiet but present when you have your baby in the birth room, or for instance, if you go to theatre for an emergency section, there would always be a neonatology doctor there ready to help. But if your baby is born in good condition and cries at birth, there is no reason why you can't have skin-to-skin, delayed cord clamping straight away. And again, for instance, at emergency section, that baby should be able to come round onto you really pretty quickly, provided they don't need additional help.
Okay. Could I have an induction with a breech baby?
It would not be recommended.
Okay.
So it's generally not recommended. We also don't what's called augment labours with the hormone drip if you're not progressing. So if you get to 6 centimetres and we give you plenty of time to progress and it's not happening, I would not feel comfortable, encouraging you to have stronger contractions.
And that's with the hormone drip
Yes.
that people know as Syntocinon, isn't it?
So I call it the oxytocin drip.
Oxytocin drip.
Syntocinon is a brand, but the oxytocin drip I wouldn't use in labour. And it would be a real exceptional circumstance where that did happen. You'd be, having individualised, tailored discussions with a super experienced obstetrician. That's not standard practice.
So if I then don't want to have a vaginal breech, I'd rather not have the ECV. Can you please talk to me about cesarean?
Of course. So if your baby remains breech towards the end of your pregnancy, you should be given the option of a planned cesarean section. And it's been shown that this option is safest for your baby, but it's not as safe for you as vaginal breech birth. And that is because it involves the surgical risks of a cesarean section, which I will talk about in the elective cesarean section chat in more detail. But it's also worth bearing in mind that if you aim for a vaginal breech birth, you have a 40% chance of having an emergency section.
Yes, okay.
So cesarean section can increase your chances of problems in a future pregnancy as well. So if you want to have a large family, multiple cesarean sections are not a good idea. Okay. And the reason why is because the scar on the uterus can become thin, and the placenta in future pregnancies can implant into that scar in a circumstance called placenta previa, which is where it covers the cervix, accreta, where it's firmly stuck, or percreta, where it invades the scar and is also on the other side of the uterus. And all of those circumstances, whilst rare, become more common as we see cesarean section becoming more and more common. So if you wanted 4 or 5 kids and you'd already had one vaginal birth and wanted to aim for a vaginal breech birth, that would be part of the discussion, what your reproductive aspirations are.
Okay.
If you choose to have a cesarean but go into labour before your planned operation, and you very much still want to have your cesarean, you would be recommended to have a vaginal examination to assess the situation, because if you're in early labour, that's still very much an option that's on the table. If you're very nearly fully dilated or fully dilated and the baby's bottom is low, you may in those circumstances be recommended to aim for vaginal breech birth, because an emergency cesarean section in advanced labour carries different and higher risks than a planned cesarean section.
Okay.
Does that
make
sense?
To both mum and to baby?
Yes, to both of you. It is more difficult to lift up a baby from deep in your pelvis in advanced labour. and it is more likely to cause things like heavy bleeding, damage to surrounding structures like bladder, bowel or blood vessels,
Okay.
blood clots afterwards for you, and
Yeah.
slightly higher risk of infection at emergency cesarean section compared to planned cesarean section at 9 o'clock in the morning on a Tuesday.
Okay.
So if that were to happen and you were in advanced labour and you were diagnosed with a breech baby, then you would always have a practitioner available to help who is trained in vaginal breech birth.
Yeah. Okay.
Okay. So if you have a planned cesarean section and then you are scanned on the day and your baby is head down, you would usually be counselled to aim for a vaginal birth if there were no other reasons why you were aiming for a cesarean.
Okay.
So I think when you put your date in the diary for when you're having your baby, that is a variable that you need to consider. Yeah.
Okay.
Okay.
Nice. Thanks, Vicky.
That's all right.
I will go away and have a think about my options.
Okay. Come back and let me know.